Welcome to my presentation on preparing you for the fascinating world of clinical infectious disease. You've already had your basic microbiology courses. You now know about bugs and the drugs. But there is the awkward transition from learning about the facts and then using those facts to solve real-world problems. My name is Johnny Wu. I'm a pharmacist, and I'm here to try to help with that transition. Now let me tell you a little about myself. When I was in university, I did pretty well. And I did pretty well because I was really good at memorizing slides. But once I got into pharmacy school, I turned out to be a pretty average pharmacy student. And once I graduated, I started working at Shoppers and then at Costco. And I did retail for about 6 years. And after about 6 years, I decided I wanted to change the environment, and I started working at a hospital where I've been working for about 8 years now. But enough about me. What about you? Chances are you also did really well in school. And you did really well in school because you have a system that you've developed, and it has served you well for over a decade. And you chose to do pharmacy because you wanted to help people at the end of the day. You also enjoyed clarity. And you chose pharmacy because you want a work-life balance. And at the end of the day, though, we are here to make a living. But statistically speaking, many of you are going to struggle next semester. And that is the reason why I'm here today. So why the class struggle? Well, one of the reasons must surely be that infectious diseases is very complicated. You might have very similar clinical scenarios that result in very different solutions. Consider, for instance, a cellulitis, and this cellulitis is in the foot. That's pretty easy. You treat cellulitis for gram-positive cocci, staph and strep. But actually, this isn't a normal foot cellulitis. It is a diabetic foot infection. People with diabetes have impaired immune system, and they also have impaired blood flow to the area. So the kind of bacteria that they grow is very different. You'll need additional gram-negative coverage, and you might need some anaerobic coverage. Wait, what if this diabetic foot ulcer is also a chronic diabetic foot ulcer? Then the treatment will be completely different, and the length of the treatment will be completely different. So you have 3 clinical scenarios that are very similar, but differ in a slight detail, and it changes the answer completely. Another reason why you might be struggling is because the environment that you're learning is very different. Before, you were given slides to memorize and you took a multiple choice test, and how well you did in the multiple choice test decided whether or not you were a good student or not. But now, there's actually a goal in mind. There's patient care, which is a very practical goal. So in real life, you're not given a multiple choice test, and if you do well in the multiple choice test, your patient lives. It doesn't work like that. And so the lectures and the practical labs are going to be very different, and that takes time to adjust. And some of you might feel that a lot of the information that I will present and that you've been presented in microbiology and infectious diseases, it doesn't really apply to the work environment that you're striving to achieve. If you're in retail pharmacy, you don't really need to know how to dose Vanco, for instance. And I think that's fair. And during this lecture, I hope to convince you otherwise, though. So why should you care? Remember, you're here to optimize pharmaceutical care and make a difference. In real life, there are obstacles to overcome, and one of them is inertia. If you want to change someone's antidepressant because the patient's experiencing a side effect, that is a noble goal. But the patient has been on it for years, and it will be difficult to change them because they've been taking it for years, and the doctor will feel the same way. It's hard to change a chronic medication no matter how solid your argument is. Antibiotics, however, are most of the time short-term, so both patient and doctor are much more willing to change the medication. Drugs generally do not cure diseases, except antibiotics. The number needed to treat for infectious diseases is very low compared to, say, statins and MI prevention. In other words, antibiotics save lives. They have a huge impact on health. Doctors, as you'll learn, actually don't really know the spectrum of antibiotics that well or the resistance patterns. So it's up to you as the pharmacist to make sure that they get the optimal antibiotic. In fact, it's no coincidence that in the hospital, the pharmacist that wields the greatest power and responsibility tends to be the infectious disease pharmacist. Also, many of you went to biology because you like learning about nature, but you found out that no one's going to pay you to look at bugs. Well, guess what? You'll use all the ecology and evolution training that your dad has been telling you is a waste of time. And the final reason that learning the basics is learning the basics is that it's the first step towards mastery. And mastery, whether it's mastery of meditation or golf or what have you, is a goal worth pursuing. More on this later. How do you learn all this information in a way that is conducive to applying in real life? Well, it would be nice if our brain was like a piece of RAM, random access memories, where you can store the memory wherever you want, and you can retrieve it whenever you want. But the brain doesn't work that way. The brain only keeps relevant information that is connected to other pieces of information. So it's helpful to know the basics of a topic so it can act as a scaffold on which to build your knowledge. So we're going to talk a little bit about how to characterize bacteria. So what characteristics do we use to organize information about bacteria? One of the most basic ways is the morphology, or how the bacteria looks under the microscope. In the field of infectious disease, the broadest differentiation is gram-positives and gram-negatives. Gram-positives accept the gram stain and pop against the background, whereas gram-negatives do not. And all gram-positives and all gram-negatives are further differentiated by their shapes. Like pasta, it comes in spheres called cocci, or in rods called bacilli. And there's also some weirdos like the spirochetes. By the way, this is a cavatappi. It's my favorite pasta shape. It's a fun pasta shape because I feel like I'm eating a bowl of giant treponema. Although not morphology, you'll often hear bacteria referred to as an anaerobe or as an atypical. But I hear you asking, do I really need to know this? I mean, for realsies? Or do I just need to know it for the test? Well, teaching about morphology is actually a favor the lecturer does for you. It helps to make generalizations that are easier to memorize when learning the spectra of antibiotics. I mean, would you rather learn what's on the left, or would you rather memorize what's on the right? Look, listen, I'm not going to pretend like it's going to be easy, or you'll get it on your first try. But for the next semester, there is a cast ensemble of bacteria, and you'll see them over and over again. It's about a dozen usual suspects, and a supporting cast of another dozen. So do yourself a favor. When you're introduced to a bacteria, try to learn its morphology. And it's okay if you forget, because chances are you'll encounter it again in the next few lectures. Once you're familiar with a bacteria, you might find that it gains a kind of personality. You might feel that bacteria is tough or sneaky or something like that. And often that is due to the ecology of the bacteria, so it's useful to know the typical living conditions of the bug. Is their typical environment hospital? Is it like full of food and oxygen and moist, like say on a human being? Or do they live in a dry, competitive, and inhospitable environment? Bugs that live on human beings tend to be more virulent because they evolved to bypass our defenses. They were, however, easier to kill with antibiotics because up until the 20th century, they never had encountered them. There's less resistance that develops to antibiotics as well. There's many reasons for this. One of them is that they tend to be gram-positives, which have their weakest link, which is cell wall, exposed for attack. In contrast, bugs that live in the soil or water or rock did not co-evolve with humans, so they're not as virulent. Unless, of course, you have an impaired immune system. They're also really good at living outside the human body, like say on bed sheets or the wall of hospitals. A sample of soil in the rich, fertile lands of Borneo will be teeming with bacteria, and each bacteria wants to outcompete the other. This competition spurs production of chemical warfare agents, which we refer to as antibiotics. Many of these bugs will have already been exposed to antibiotics throughout their evolutionary history. So a bug that has, through its lineage, never encountered an amoxicillin molecule might already produce a beta-lactamase that cleaves the amoxicillin. It is already resistant. The brain does not like abstraction and will try to organize ideas spontaneously. Over time, I've started ranking bacteria in a tier list. For those of you who are unfamiliar with the scale, S is God tier and D is, well, crap tier. On the lowest tier, we have bacteria that are susceptible to pretty much all antibiotics and for some reason have never really bothered to evolve. For Treponema, though, that seems to be unnecessary because it's quite successful regardless. Next tier, we have bugs that require broader agents and are sometimes develop resistance. By the way, in the field of microbiology, they like to annoyingly reuse root words. Aeromonas is unrelated to Aerococcus, and treatment is vastly different. The B tier have bugs that are tougher, either because of limited treatment options or a special virulence. A tier are bugs that cause a lot of grief, and you can expect resistance. For instance, the wild type of Stenotrophomonas, sometimes referred to as steno, for instance, comes with not one, but two carbapenemases. S tier, I won't speak of. So this scale might seem whimsical, but it does help me guide how aggressive empiric treatment should be. And over time, you might find yourself organizing information in a way that feels natural to you. This just happens to be my example. You not only need to know about bacteria, you need to know about the drugs too. Shocking, I know. Arguably the most important property of an antibiotic is its spectrum. When I was asked initially by Dr. Crandall to create this presentation, I'm pretty sure this is what he had in mind, because this is the scales and arpeggios of infectious disease. Now, you probably had this lecture in the past, and you'll probably have more of the same in the future, but I think this repetition is worth it due to its importance. Beta-lactams act on the cell wall. It is exposed in gram-positive bacteria, but it is protected by a second leaflet in gram-negative bacteria. The outer leaflet gives bacteria -2 speed, but +5 defense by blocking antibiotics from access to its cell wall by expressing or underexpressing certain proteins in its outer leaflet. So it makes sense that the earliest beta-lactams, penicillin, really only works for gram-positive bacteria. So penicillin killed easy-to-kill gram-positives. This includes streptococci, Aerococcus, and oral anaerobes. They also cover enterococci, but I'd hardly call them easy to kill. Amoxicillin is a synthetic human-invented upgrade to penicillin. It covers everything penicillin does. In addition, it'll kill H. flu, and it'll kill easy-to-kill gram-negatives. So these are often referred to as the PEC organisms for Proteus, E. coli, and Klebsiella. Once you expose bacteria repeatedly to antibiotics, you'll end up selecting for resistance. Duh. One mechanism of resistance to beta-lactams are by beta-lactamases. So we participate in this arms race and develop anti-defenses that block beta-lactamases. These are called beta-lactamase inhibitors, an example being clavulanic acid. Now, as an aside, clavulanic acid is in itself a beta-lactam antibiotic. You'll learn in your pneumonia lecture that strep pneumo has low-level resistance to amoxicillin, so it requires either high-dose amoxicillin or alternatively amoxiclav. But the mechanism is not by beta-lactamase production, but by mutation of the penicillin-binding protein subtype 2. Amoxiclav overcomes resistance not because it blocks beta-lactamase production, but because clavulanic acid inhibits another penicillin-binding protein subtype. Now, didn't I tell you that infectious disease is endlessly fascinating? Anyway, by inhibiting low-level beta-lactamases, you cover MSSA, methicillin-susceptible Staph aureus, gut anaerobes, and the easy-to-kill gram-negatives that develop resistance, the PEC organisms. Cloxacillin was developed solely for the purpose of treating MSSA. As an aside, it does happen to treat strep, but it's basically used just for MSSA. Cloxacillin, MSSA. Now, piptazo covers basically everything. I mean, in Canada, we would call this a big gun. Perhaps too big a gun, depending on the clinical context. It covers nearly everything except atypicals and bacteria with either intrinsic or acquired resistance, and there's not a whole lot of them. You'll often see piptazo used when Pseudomonas is suspected, or by nervous clinicians who just want to cover everything and don't really care about their grandchildren's access to viable antibiotics. Similarly to penicillins, cephalosporins start with a discovered molecule from nature that has a narrow spectrum, and human ingenuity progressively improved upon it. Cephalosporins are often lumped into generations because similar generations will cover the same bugs. Now, this convenience really only works for the first 2 generations, and it kind of breaks down for the 3rd to 5th generation, but we'll just ignore that for now. Generally, the higher the generation, the higher the gram-negative potency, but it tends to be at the expense of gram-positive coverage. All have gram-positive coverage to some extent, though, and this includes Streptococcus species like Strep pneumo, Group A strep, and covers MSSA. Now, it is worth noting that none of these cephalosporins will cover enterococci. So the first generation is basically a souped-up amoxicillin, and it tends to overcome the penicillinase-producing PEC organisms. In addition, it will cover MSSA, but not enterococci, as I mentioned. The second generation was developed to overcome resistance to the first generation. Now, this lecture is recorded in 2023 when a small majority of PEC organisms are susceptible for the first generation but are considered unreliable. So we use a second generation when we have a strong suspicion of a PEC organism. By the third generation, we get to really specialized molecules that were developed for a specific purpose. Ceftriaxone is a multi-purpose hospital workhorse. Fortunately, it doesn't have pseudomonas coverage, or fortunately, depending on your viewpoint. Ceftazidime it's all right for a lot of things, but when you see ceftazidime, it's typically because you grew Pseudomonas and you wanted a more narrow option to piptazo. Cefixime is often referred to as a third-generation cephalosporin, but it's much more limited to the other third generations. The spectrum is much more narrow. It's mostly useful for PEC organisms that have developed resistance to second generation, but not the third, or for gram-negative cocci such as gonorrhea. There's also a fourth and fifth generation cephalosporin that specializes into treating MRSA. Examples are ceftobiprole and ceftaroline, but that's really getting into the weeds, so I'll just stop it there. Carbapenems, in short, cover almost everything except atypicals. There are some variation amongst carbapenems, such as ertapenem not covering Pseudomonas and imipenem not covering Morganella. But life would be much simpler if you could use carbapenems for everything. And trust me, a lot of doctors will try. Stewardship be damned. Carbapenems are a plausible answer to most questions, but in real life, they're impractical or irresponsible. So they'll seldom be the answer to both your tests and in real life. Now, moving on from beta-lactams, we have macrolides. In a one-liner, macrolides are for pneumonia. They cover almost all organisms you would find in community-acquired pneumonia and cover nothing else. With the asterisk being that, unfortunately, there's growing resistance from staph and strep pneumo to macrolides, so they can no longer be relied upon for monotherapy in pneumonia. But they're still great for atypical coverage when combining with other antibiotics. And the atypicals in the context of pneumonia, by the way, are Chlamydophila, Mycoplasma, and Legionella. You can bet that's going to be on some quiz or test in the future. And aminoglycosides. Aminoglycosides. An oldie, but a goodie. Now, if I were to design a useful antibiotic to treat resistant organisms, I'd design something that's, IV only, because you would really only want it for the hospital. But I would also make sure that it has some terrible side effect, but that is manageable with some skill. Now, the fear of this terrible side effect will prevent its overuse, and the resistance will be minimal. Now, aminoglycosides are the embodiment of this idea. The side effects are nephrotoxicity and autotoxicity. They're both common, severe, and debilitating, but you can manage their probability by doing some good old TDM, some therapeutic drug monitoring. Now, this is where you come in as a pharmacist, by the way. This is your value add. Aminoglycosides cover mostly gram-negatives, although there's, in some clinical context, they'll be used as synergy with beta-lactams for gram-positive coverage. The spectrum looks kind of weak, but again, this is because they have a limited use. You'll often see them used for organisms that are resistant to sometimes literally everything else, including carbapenems for quinolones, sulfonamide, fosfomycin, and these organisms will be strangely only susceptible to aminoglycosides. Aminoglycosides are as feared as they are respected. So if you want to be useful in your organization, you should know the aminoglycoside kinetics because no one else will. Next, we have the humble tetracyclines. It really doesn't have the respect and admiration it deserves. The usually sober John Hopkins Antibiotics Guide describes using doxy to treat Legionnaire's disease as quote-unquote a pea shooter doing a cannon's job. It doesn't deserve that kind of shade. It'll cover most gram-positive, yes, even gram-positive bacilli. And yes, it'll cover even MRSA. In London Health Sciences, all of our MRSA, in fact, are susceptible to doxycycline. It'll cover atypicals and gram-negatives, except for Pseudomonas and some of its lesser-known ilk. It'll treat Coxiella, which causes Q fever. Now, the Q is often retconned as query fever, but it was originally named Queensland fever. Now it's gauche to name diseases after places, so we just say Q fever. Astonishingly, it also treats malaria to some extent. Now, why is that shocking? Well, malaria is a eukaryote. Doxycycline is specific to bacterial ribosomes and spares our ribosomes. That's why it has very few side effects. From an evolutionary perspective, Plasmodium is far closer to us than to bacteria. So why does it treat malaria? Because Plasmodium's life cycle relies on an organelle called the apicoplast, which is of bacterial origin. Now, luckily, its broad spectrum is matched with a pretty good safety profile. As long as you don't have growing teeth or are growing someone who is growing teeth, doxycycline has very few side effects. As mentioned, it binds to bacterial ribosomes, but not our ribosomes. And as you know, most broad antibiotics tend to increase the risk of C. difficile. Tetracyclines actually have a lower risk of C. difficile than not having had any antibiotics at all. And that's because it inhibits C. difficile growth. Of course, you never use it to treat C. diff, but it's a good option for broad coverage in someone with a high risk of C. diff, like someone who's had C. diff in the recent past. Now, all that being said, if on your hospital rotation you suggest using doxycycline to treat something like MRSA bacteremia or meningitis, you'll get laughed out of the room. Doxycycline appears to inhibit a lot of organisms in vitro, but we live in a world where clinical evidence matters. So unless doxycycline has been studied in that particular clinical context, it is typically deemed irresponsible to use it as first-line therapy. You know those movies where the world is in peril and the only person who has the ability to save it is an extremely skilled but untrustworthy criminal? That's how I feel about fluoroquinolones. They can do the work when no one else can, but underneath its utilitarian image lies darkness, hepatotoxicity, tendon rupture, aortic aneurysm rupture, QT prolongation, phototoxicity, permanent neuropathy. This is just a sample of how fluoroquinolones will shank you when you turn your back. But man, are they useful. They have excellent penetration into whatever compartment you can imagine. Bone for osteomyelitis, CNS for meningitis, prostate for prostatitis, no problem. They also have nearly 100% bioavailability if you're into that kind of thing. Fluoroquinolones have traditionally been split into urinary or respiratory fluoroquinolones, which corresponds to their proclivity towards either gram-positives or gram-negatives. Gram-positives for pneumonia, gram-negatives for urinary tract infections. However, there's sometimes a bit of a crossover. You'll sometimes see ciprofloxacin used for pneumonia when Pseudomonas or another susceptible gram-negative has been implicated. And you'll sometimes see levofloxacin used for UTI. However, you'll never see moxifloxacin used for UTI because of inadequate concentrations in the urine, nor will you ever see norfloxacin used for anything other than a UTI because of inadequate serum levels. Now, of note, ciprofloxacin is the only oral agent that will cover Pseudomonas. I mean, you might see infectious disease use levofloxacin because of some very reasonable in vitro data, but for the most part, we use ciprofloxacin. They'll cover atypicals, even tuberculosis. Moxifloxacin will even cover anaerobes. But that's a trade-off because by covering anaerobes, you also increase the risk of C. diff. Because they have such a broad spectrum and a unique mechanism, it is sometimes the only susceptible antibiotics on some isolates. That being said, there's a lot of resistance out there. You can't even trust Cipro to cover severe Pseudomonas infections until susceptibilities are released. And it's not just Pseudomonas. In some diseases, such as typhoid, fluoroquinolones are indicated unless they have recently traveled to specific parts of the world due to rampant resistance there. What was the first antibiotic? If you said penicillin, discovered in 1942, you would be wrong. There was an antibiotic discovered in 1932. It was already discovered before then, actually, but it was used as a dye. Sulfonamides were the first antibiotics that were used to treat infectious diseases. Just kidding. It's actually salvartin, or progenitors, rather, but its progenitors were discovered in 1907. Yes, that is a bunch of arsenic molecules in there. And yes, it definitely did arsenic-y things to patients. But hey, it sure beats neurosyphilis. And for their contribution to mankind, Ehrlich received a Nobel Prize. Now, if only he had done it a bit sooner, who knows what kind of works Schumann and Schubert would have composed. Hot take alert. Wish it was Brahms instead. Anyway, I digress. Septra covers a whole lot. Most gram-negatives and most gram-positives, except Pseudomonas and Enterococci. Starts to notice a pattern here. It is first-line therapy for the A-tier Stenotrophomonas, for which you need absolutely massive doses. Its mechanism is to inhibit folate synthesis, and guess what? Fungi need folate synthesis too. So Septra treats some fungi such as Neuromycete jirovecii. And surprisingly, it also treats lice. Now you would take the Septra by mouth, and they'll go in your blood, and then the lice will drink up the blood, and then the lice are exposed to the Septra, and then they die. Now the reason isn't that it inhibits the folate synthesis of lice. Rather, it is thought that the mechanism is through killing Wolbachia, which is a fascinating bacteria. You may have never heard of Wolbachia, but arguably it is the most impactful pathogenic bacteria on Earth, provided you don't interpret the question with an anthropocentric lens. It is a scourge of arthropods. Wolbachia can either kill hosts or it can help hosts. Really fascinating stuff, but well beyond the scope of this lecture. You can read We Contain Multitudes for more details. Clindamycin is good for staph and strep, so this includes potentially MRSA, even though resistance rates means that susceptibility will need to be confirmed first. It's also useful for anaerobes. You see it often for skin infections or dental infections in the community. We tend to avoid clindamycin like the plague in the hospital, though, because of the high C. diff risk. But in the hospital, there's still a special role for clindamycin when treating toxic shock syndrome and necrotizing fasciitis, because the theory is that it inhibits toxin production by the group A strep. If you're going to be working in the hospital, vancomycin will be of such importance to your work that it should really be the first antibiotic to introduce. MRSA and ephesium will need vancomycin, and vancomycin will need you. Doctors are certainly not going to care about pharmacokinetics, so the patient's kidney's fate are entirely in your hands. Vancomycin treats pretty much all gram-positives because instead of inhibiting an enzyme, it inhibits a component of the cell wall, so mutations are much less likely to produce resistance. And by covering up the cell wall, the bacteria can't cross-link their components of the cell wall, and then they lyse. Now, recall that gram-negatives have an outer phospholipid membrane that will occlude large molecules. And vancomycin is indeed huge. There is no gram-negative coverage at all, except, surprisingly, Neisseria, which is susceptible to vancomycin because it has a mutation in the envelope. Now, this is referred to frequently in early papers after the discovery of vancomycin, but it is not mentioned much after the 1980s. And some things that should not have been forgotten were lost, and history became legend, and legend became myth. So yeah, definitely don't recommend Vanco for Neisseria, but I thought I'd just put it in there to show that nature's freaky. In fact, if you go back to my presentation, you could probably take issue with nearly all my statements by citing an exception of some kind. Right, so vancomycin. The peptidoglycan cell wall in bacteria is highly preserved. So when I say all gram-positives are susceptible to vancomycin, I mean all of them. Well, no, except those who have managed to express the vancomycin resistance gene, but those are quite rare, especially in Canada. So, as I mentioned before, it's really the workhorse to treat methicillin-resistant Staph aureus. The MRSA is resistant to methicillin and actually pretty much all beta-lactams except for the 5th generation cephalosporins. And the reason why it's resistant to all beta-lactams is because the mechanism of resistance is a PBP mutation. It is not due to expression of a beta-lactamase enzyme. So this mutation cannot be overcome by giving a beta-lactamase inhibitor. And so not even piptazo would treat MRSA, and not even the gigachad carbapenem. Vancomycin will treat ephesium, which normally laughs when exposed to nearly every other antibiotic. And lastly, it's first-line therapy for C. diff, which, it's a gram-positive organism. It's a gram-positive bacillus. As mentioned before, vancomycin needs a bit of skill and experience to manage, and it is a pain to discharge patients who need vancomycin. Enter dalbavancin. It's the antibiotic that vancomycin's girlfriend tells him not to worry about. It's basically everything that you wish that vancomycin was. It's once a week. It's more potent. There's no monitoring involved. And it's actually a good thing that it costs an arm and a leg, or else resistance will render this class useless. And if you can't afford dalbavancin, you can always try the Bayesian calculator that I wrote at vancovanco.com to help with dosing vanco. Metronidazole kills anaerobes. There's very little resistance. And it's actually not a whole lot else to say about metronidazole. Metronidazole is kind of like Michael Cera. I mean, he's excellent as being Michael Cera. Just don't expect any range from him. Linezolid has a distinction of being the first new class of antibiotics in decades when it was released. And it was a small molecule that you could take by mouth. Now you could treat MRSA and even vancomycin-resistant enterococci, or VRE, with an oral option. And initially, it was ridiculously expensive. You think thousands of dollars a week expensive. There is no cross-resistance between it and the other ribosome or translation inhibitors. And one of the big reasons it's not used more is because of the fear of serotonin syndrome, which was probably overblown. And another issue is myelosuppression when it's used for more than 2 weeks. And that fear is definitely not overblown. Daptomycin is another agent that is used to treat resistant gram-positives, which has no gram-negative coverage at all. It's used when vancomycin fails, or for VRE. It can't be used in pneumonia, though, because it's disabled by the surfactants in the lung. This is a summary of the mechanisms of common antibiotics. Frankly, the mechanism very seldom has an impact on therapeutics. It's not like you try to mix and match mechanisms, or you try to avoid two of the same mechanism. So mechanisms are usually irrelevant in practice. Sometimes knowing the mechanism helps to explain some things, though, like clindamycin as an adjunct in toxic shock syndrome to suppress expression of toxic genes by a group A strep. Another example is beta-lactams being bad in urinary tract infections because it requires bacteria to be surrounded in a hypotonic environment in order to lyse, and this is not always the case in urine. And another example is beta-lactams and aminoglycosides in synergy for treatment of gram-positive bacteria. But for the most part, mechanisms of actions are just an academic interest. You'd use the aforementioned combinations not because of a problem-solving thought process, but because it's in the guidelines. Now that you know the spectrum of antibiotics, you have to be able to go backwards as well. You're given an organism at a particular site, and you should be able to list off the list of antibiotics that will treat these. It's a favorite quiz for residents and interns to ask what covers Pseudomonas and MRSA. So be prepared. Atypicals and anaerobic coverage also comes up a lot in practice, so it'll be wise to be familiar with these as well. As a fun non sequitur, this figure was published from the POET trial published in 2019. The study was a randomized controlled trial comparing intravenous to oral step-down for gram-positive endocarditis. Oral step-down for endocarditis, or even bacteremias, was a radical and unfathomable idea in Canada at the time, and in some circles it still is. They studied staph and E. faecalis, and depending on the resistance, the protocol prescribed a certain regimen. Now, do you see anything unusual here? For Staph aureus, they use amoxicillin. This trial was done in Denmark, where they tend to be just better at everything, and one of those things being stewardship. Their antibiotic stewardship is so good, they don't just have MSSA, they have PSSA, penicillin-susceptible Staph aureus. PSSA was the wild type back then, before penicillin was developed and used, but it quickly acquired a penicillinase. So by the late 1940s, not even a decade after it had been in use, penicillin and amoxicillin were rendered useless. An infectious disease doctor once told me that there's a case where a World War II vet developed an infection, and the infection was deep-seated in a piece of shrapnel. And when this infection was cultured, it turned out to be none other than penicillin-susceptible Staph aureus. It was like a time capsule, except in someone's leg. Now, I would like to take this opportunity to get the first word on some controversial topics before your minds are poisoned by other pharmacists. You'll often hear things like, we want beta-lactams because they're bactericidal instead of bacteriostatic, like vancomycin. Most clinicians believe that bactericidal means what its etymology would suggest, that it kills bacteria. And conversely, bacteriostatic means what it implies, that it doesn't kill bacteria, it merely stops growth of the bacteria. In reality, there is a concentration where every antibiotic will inhibit growth, and this is called the MIC, the minimum inhibitory concentration. And there's a concentration where it will kill it, a minimum bactericidal concentration. In other words, all antibiotics are bacteriostatic and bactericidal, as most people understand the term. Bacteriostatic activity has been defined as a ratio of the MBC to the MIC of more than 4. Now you might think that maybe this has some relevance because maybe the lower the ratio, then the more likely it is to actually kill bacteria in the human body. But none of these concentrations are related to the levels seen in human medicine at all. This is also completely ignoring the complex interactions between the bug and the drug and the body. So bacteriostatic and bactericidal are terms used by microbiologists and have very little relevance to clinicians. I'll tell doctors not to use Vanco all the time because it's bacteriostatic, but that's because I have an agenda. And I also cross my fingers behind my back when I say it, because it's a bunch of baloney. There are many reasons why vancomycin and macrolides are kind of suck, but it's not because they're bacteriostatic. Another myth is that high bioavailability antibiotics are inherently better. They argue that the IV is better than PO because IV is 100% bioavailable. And actually, by the time your kids are in pharmacy school, I bet that's going to be proven a myth too. And they'll say when you step down from IV, you see, you want something that's high bioavailability like linezolid or Cipro. And I hope this doesn't ring true to you at all. With antibiotics, the real patient is the bacteria. Say, close your eyes. Pretend you're a bacterium, just doing your bacterium thing. And then bam, there's suddenly a swarm of antibiotics on the horizon. Well, what are you worried about? How many attackers you're going to be exposed to, right? Right? Well, those who care about bioavailability want you to think that the bacterium lives or dies by also considering how much antibiotic your host poops out. There's an overwhelming number of invaders at my doorstep, but I know that my host pooped out the same amount, so I think I'm going to live, thanks. I hope this sounds as ridiculous as it actually is. It kind of reminds me of my son, who is happy with the fruit I give him after he compares what I gave to his sister. You just eat your food, Owen. Your satiety will not depend on your sister's. As a disclaimer, most discussions about bioavailability are not really about bioavailability. They're about beta-lactam versus non-beta-lactams, which is its own thing and is a current active topic of research. Lastly, most of your lectures are going to be either from lecturers in Toronto or an academic center. And they'll see more severe cases. More patients will have been exposed to hospitals abroad. And your lecturers will be up to date with guidelines, which often come from the United States. And both will want you to cover MRSA and Pseudomonas under certain criteria. And these criteria will be on your tests. In reality, whether or not you need to cover for either of these really depends on your practice site. For the purpose of your education, go by what your lecturer tells you. Just don't be surprised when you graduate and you find out that you don't need to cover for Pseudomonas or MRSA for every HAP or every diabetic foot ulcer. Okay, so that was a refresher on the basics for building knowledge in infectious disease. But what about quick memorization when you can't be bothered to connect it to some underlying knowledge? That is, rote memorization. Well, unfortunately, the brain doesn't really do rote memorization. But what if you need something that requires rote memorization? You can always do mnemonics. You know what mnemonics are. I'm just going to remind you that they're powerful. You should try to use them whenever you can. The downside to mnemonics is that you do have to put some effort into creating new mnemonics if you're not going to reuse an old one. Flashcards. Merely creating a flashcard is a good learning aid because there is some level of active interpretation of the material. You need to be able to understand the material to some extent in order to condense the information into a flashcard. And it's effective because it uses active recall. We see a prompt, you actively try to remember the corresponding thing. And this helps to move information from short-term memory to long-term memory because it cues your brain that this is important information. Thinking about your thoughts is known as metacognition. And you thought that meta had no cognition. Thinking about what you know also helps to move things from short-term to long-term memory. And furthermore, flashcards are typically used repeatedly, and we all know that spaced repetition is an effective memorization technique. Now, to be frank, I never used flashcards, but I have a lot of friends who used it to great effect. For me, it was too much work, and my writing was terrible. And it's not like I could just type out the flashcards on the computer because it seems that using a computer to type out information doesn't have the same effect as writing it by hand. A bit of a personal story. When I started at the hospital, it had been 6 years since pharmacy school. I knew the change from community pharmacy to hospital pharmacy would be tough. But I thought, hey, I remember a lot of pharmacology despite this use over the years. Now, back then, the Bachelor of Pharmacy program didn't teach as much now as, about hospital-specific topics, and also my knowledge was 6 years old. Also, whenever you work at a tertiary academic center, you're going to be highly specialized. For instance, no matter how much of a survivalist you are, You'll never be good at eating ants as an ant eater. I was in shock when I arrived, and I found myself being completely ineffective in my new environment. There was simply too much information to learn at once. To memorize something at school, I would try to understand the rationale behind the idea of a number, and that would help cement that information in my mind. But I didn't have time to do this at work. And the whole experience was like drinking from a fire hose. So to cope with this, I turned to memorization techniques. Moonwalking with Einstein is a piece of participative journalism where the author competes in a memorization competition and actually eventually wins one of the events in the 2006 championship. The book talks a lot about the science and the history of memorization, but it also touches on some techniques from competitive memory athletes. One of them is the major system. It's a way to memorize long strings of numbers by converting them to consonants and forming words and images. I never really found a use for this in pharmacy practice, but it exists. The Memory Palace, on the other hand, was instrumental to helping me store lots of esoteric information and relatively quickly. It works by connecting images of something well known to you and a new piece of information. This is typically an image or a mnemonic. And then you take this image and then you store it in a physical location that you know very well. This is referred to as the Memory Palace. For many people, the Memory Palace will be a childhood home. For me, it was the DE dust map in Counter-Strike. So Candida albicans is usually susceptible to fluconazole. Other species of Candida, like Candida glabrata and cruziate, tend to be resistant to fluconazole and need echinocandins, such as caspofungin. So caspofungins and other echinocandins are often thought to as the carbapenems of Candida in that regard that overcomes resistance. One interesting exception is Candida parapsilosis, which has higher MICs for echinocandins than it does for fluconazole. And I learned this about 5 years ago and stored it neatly near one of the crates in my Memory Palace. I haven't seen a Candida parapsilosis since then, until a year ago when infectious disease was consulted and placed one of my patients with a parapsilosis candidemia on caspofungin. I walked to the crate and dusted off this information and contacted infectious disease. And the patient was changed from caspofungin to fluconazole. Learning and memorizing is a skill like anything else. Don't expect a perfect croissant your first try, and likewise, you shouldn't expect to have a useful memory palace on your first try either. You may find that this technique doesn't work for you at all, but what is important is that you recognize that people generally don't instantly rote memorize information. They use some kind of trick or technique, even if they don't call it as such. And it'll be useful for you right now as a student and when you start working to find a way to remember information efficiently. What if instead of having 2 days to study for an exam, you had 2 weeks or 2 years? In reality, everything is possible given enough time. If I was given enough time, I could become a world-class chess player or a good father. But I can't, because no time. In pharmacy, you'll be asked to read a lot, in books and articles and stuff. Sure, I mean, when you're an undergrad, they probably assign you a textbook to read, but you probably got away with just memorizing slides, and maybe you just used the textbooks just for the exercises, like deadlifting. I guess you could just read therapeutic choices and lecture notes in pharmacy school, but you'd be losing out. Without the context that reading textbooks provide, you'll forget the material after the test and have an incomplete understanding of the material, and this deficit will compound over the course of your education. So it's best to do your readings. But with pages and pages to read every day, wouldn't it be nice if you could double or triple your reading speed? It turns out to be not that hard. The average reading speed is between 200 to 300 words per minute, but a good speed reader will read over 600 words per minute without a loss in comprehension. So how do you do this? If you're really interested, you can Google it. There's a lot of resources out there. Various strategies exist, including using your index finger to move along the text to force your eyes to move at a certain pace. And a frequent barrier to reading speed is to read at the same speed as one sounds out the words. You're essentially reading out loud, but not making the noises with your mouth hole. When you're reading out loud, you're limited by how quickly one speaks in your region and physiological limits of your speech producing body parts. But you can suppress this, what we call subvocalization, either through practice, or some people, for instance, will just repeat a series of words like 1, 2, 3, 1, 2, 3 to keep their Broca's area distracted while the rest of the brain does the real work of reading. How fast do you read? As a quick test, I'll put up a passage and you read it, but try to read it as if there was a reading comprehension test at the end. Don't just move your eyes across and skim the text. Once you finish, there will be the words per minute at the bottom to indicate how fast you were reading. If you modified your YouTube playback speed to 2x because you wanted to get out of this lecture as quickly as possible, now is a good time to change it back. Are you ready? 3, 2, 1, go. Some of you will be voracious readers and will already read at 800 words per minute. I speed read at 700 words per minute when my material is utilitarian, and as low as 200 words per minute when it's for pleasure. So 700 for cardiology papers and 200 for infectious disease papers. So I hope this exercise has showed you whether or not you would benefit from practicing speed reading. Perhaps my favorite time management technique ever is the Pomodoro technique. My biggest problem as a student was that I was constantly distracted. I would crack open a book and then make excuses to step away. Need to drink water, need to go to the washroom, need to check my emails, yada, yada, yada. It's a pretty common experience, I'm sure. I came across something called the Pomodoro technique, which changed the way I studied forever. I still use it to this day for my days off when I want to be held accountable for my time. And it goes something like this. Number 1, you plan your tasks and break down large tasks into 25-minute chunks. You focus on that task for 25 minutes. You can check off the Pomodoro as complete when you work without distraction for 25 minutes. Take a 5-minute break, a real break, not the Ross Rachel kind of break, not a break. After completing 4 Pomodoros, you can take a longer break. By the way, I'm aware that the Pomodoro is an Italian term, so that the plural of Pomodoro is really Pomodori, not Pomodoros. But just like how octopus can be pluralized as octopodes, as is correct by its Greek origin, and octopuses, because that's how we pluralize in English, it's also acceptable for some reason to say octopi, which is a Latin pluralization of a Greek word in English. Makes no sense, but blame Shakespeare. He's the one who invented English, not me. This is an example of a list of tasks and the number of Pomodoros that you expect it to take. When you have completed a Pomodoro, you check one off, and then another off. So why does this system work? The reason you don't just list tasks and ad hoc create a Pomodoro as you go along is that planning for a certain number of Pomodoros trains you to be better at guessing how long a task will take. It also allows you to take a finite chunk of time and allot it between your tasks so you don't unexpectedly spend all your time on a single task. You ever heard of something called Parkinson's Law? It states that work expands to fill the time allotted for its completion. So the more time you allot a task, the more time you'll spend on it. If you're a busy person and need to get tasks done, it's therefore productive to allot a finite amount of time to each goal. For me, the game changer was that in order to achieve a sense of accomplishment, which is checking off that Pomodoro, I would need to be not distracted. Studying for 10 minutes only to get distracted and unable to check off that box was sufficient deterrent that procrastination and distraction were no longer an issue. But that was for me. Your mileage may vary. You are an adult. You know how to adult, and you probably don't need some schmo to tell you how to live. But I will anyway. Over the dozens of books I've read in my life, flow is probably the most influential. Dr. Csikszentmihalyi was a positive psychologist. The psychology you'll learn at school is mostly negative psychology, the study of what's wrong with people. Positive psychology studies what makes people happy. But what is happiness? We have known, at least since the start of recorded history, that having what we want won't lead to happiness, although we keep thinking it will. Happiness, or joy, as many of us think of it, is fleeting. We all know the example of how winning the lottery does not improve happiness, and that dentists, who are more rich often than not, have the highest suicide rates. By the way, neither of these statements are completely true. What the late Dr. Csikszentmihalyi studied was the human experience. He asked study subjects from all around the world, from all walks of life, to write down what they were doing and how they felt. Achieving a goal made people feel good, yes, but it was transient and only brought about more goals and unhappiness. There were activities, though, that people felt consistent enjoyment, and those activities had a common theme. Several people described their flow experience using the metaphor of a water current carrying them along. It was like floating. I was carried on by the flow, they would say. Okay, great. But how? And what does this have to do with infectious disease? Flow have the following 6 factors in common. This lecture is posted on YouTube. You can just pause the video and read them instead of me reading it. But specifically, what kind of activities lead to flow? While they differ from person to person, it can be playing an instrument, prayer, or sport, or games. In the latter two, you've probably heard of the concept in the zone, which refers to flow. In fact, if you're a normal human being, you've experienced flow before. Flow involves some form of mastery in a demanding task. Watching television was one of the most commonly reported activities, but generally does not involve flow. The exception are people who think about the television medium in a deeper level, like those in the field who actively think about things like lighting and composition. As it turns out, the task of passively watching television is not sufficiently demanding to engage in flow. But of course, when you engage in a novel demanding task, the first feeling you get is probably frustration. So it's not until you reach some level of mastery that you engage in flow. So what does this have to do with anything? Well, there is a movement in the younger generations to have a healthy work-life balance and to recognize that work is just a means to earn a living. And I agree with this to a great extent. But I don't really agree with quiet quitting when you're in healthcare. Quiet quitting is when you do the bare minimum at work as a protest to things like capitalism or low pay or the Leafs never getting past the first round of the playoffs. But when you are at work, just like when you're in school, your time is already booked, it's already spent. So make it count. Work to be better and to be engaged in what you do. Because if you try hard to be good at what you do for a living, with some luck, you'll spend your working hours in flow, and you'll never have to work a day in your life. Now, I personally do get in the zone when I'm verifying orders or reviewing antibiotics for my patients, but it took a lot of work to get here. So even though ID might not be your cup of tea, it pays dividends to be actively involved in trying to master your craft. Everyone encounters hardship. You have experienced it in the past and will face it in the future. It is as much a part of living as love or breathing or the Leafs flubbing the playoffs. You might lose a job, a friend, or get divorced. life happens. Stoicism is a Greek philosophy that to live a good life is to practice virtue. You can't control the externalities of life, but you can control how you react to them. Now you're probably thinking, oh, what is he on? Philosophy? Isn't that the course goal between visual arts and interpretive dance? I mean, that would be such a U of T attitude to harbor. Ever heard of cognitive behavioral therapy? It's an evidence-based process to treat mild depression. It will be covered in your major depressive disorders lectures. And as it turns out, its founders cited Stoicism as its philosophical origin. There's also a lot of papers on the benefits of practicing Stoicism if you need further convincing. Stoicism is a very practical kind of philosophy, and I truly believe that it will benefit you. You might find that the image that you have built for yourself, for instance, or that your family has built for you, start to crumble under the reality that pharmacy school is much harder than you thought, and you are indeed just average. But why must you be upset to be average, or even below average? Someone, by definition, must be average, so why be upset that it must be you? A Stoic would say, you cannot correct an old grade, but there's no point to lament it. However, you can control how you respond to it. This is an opportunity to practice patience and hard work, and to be better the next time. The tenets of Stoicism are pretty simple, but I'm probably not the best teacher. I'm a pharmacist and not a philosopher or a lecturer. And this is a lecture on microbiology, not philosophy. But I do encourage you to read Marcus Aurelius' Meditations or The Obstacle is the Way by Ryan Holiday. I hope you won't need it for your infectious disease lectures, but if you do, Stoicism is a good way to build resilience in your life and face the many challenges that lay ahead in your career. On that note, thank you for attending my TED Talk. I hope you're still awake. And if you have any feedback on additional topics you would have thought would be beneficial, or you want to tell me what really sucked about my presentation, you can email me at admin@vanco.com. Thank you, and best of luck in the future.